Let us start, sir. You ready, sir?
Yes, I'm ready.
Okay. I welcome once again each and every participant to this presentation. Today we have our most important speaker from Salem, Dr. Vishnu Prasath. He has done his F&B from Ganga and he is currently hosting one fellowship F&B in SKS Hospital, Salem. He will be presenting a talk on his pyogenic spondylodiscitis and he will present his experience of about 50 cases to us. Over to you, sir. You can start.
Okay. Good evening. Good evening to everybody. So I'm Dr. Vishnu, working as a consultant spine surgeon at SKS Hospital, Salem, Tamil Nadu. So I'm going to share my experiences regarding pyogenic spondylodiscitis. So whenever we send a patient of infective spondylodiscitis to MRI, most often the radiologists give a report as infective spondylodiscitis, most probably a tuberculosis, without thinking about pyogenic etiology. So seeing this report, many surgeons start the patient on empirical antituberculous drugs without getting a biopsy done. So this is one of the major problems we face in our country. So coming to pyogenic spondylodiscitis, the incidence is around 6% to 19%, and the incidence is increasing because of better understanding of the pathology, improved diagnostic facility, and rise in risk factors. So in our center, we have seen around 143 patients of infective spondylodiscitis in the last 7 years, out of which 91 were diagnosed to have tuberculous infection and 49 patients had pyogenic infection and mixed infection in 3 patients. So coming to the risk factors for pyogenic spondylodiscitis, the most common risk factors are diabetes mellitus, renal failure, and immunocompromised states. In my place, we see many patients having chronic steroid intake for many conditions coming up with infection. So coming to the pathophysiology, the most common route of infection in pyogenic spondylodiscitis is hematogenous spread, either via spinal artery or via paravertebral venous plexus. The other less common routes are direct invasion secondary to spinal procedures, that is iatrogenic introduction of organisms into the disc space, or spread from adjacent infections such as paravertebral abscess or pharyngeal abscess. The most common identifiable source of bacteremia is genitourinary tract and soft tissue infection. So whenever you encounter a patient of spinal infection, we should always ask leading questions regarding extraspinal infection in the recent past, like whether you had any urinary tract infection or burning micturition, any soft tissue pus formation, something we should ask leading questions. So coming to post-operative iatrogenic discitis, a risk of postoperative iatrogenic infection without instrumentation is less than 3%. With instrumentation, it increases to 12%. The incidence of infection in lumbar spine surgery is more compared to cervical spine. And whenever we use operating microscope or loop, theoretically there is an increased chance of infection because of increased bacterial shedding. There is always a delay in diagnosis in pyogenic infection because most of the patients have non-specific symptoms like mild back pain here, there, and whenever they get some fever, the local physician, they start on some oral antibiotics. They mask the symptoms and there is a delay in diagnosis. Coming to imaging modalities, the first modality is the X-ray, where the initial phases we see erosion of the end plates. Vertebral body destruction and kyphotic deformity are very rare presentation in pyogenic infection because they present earlier compared to tuberculous patients. So these kind of typical vertebral body destruction and kyphotic deformity is seen mainly in tuberculous infection and very, very rarely in pyogenic infection. So MR is the single most useful radiologic investigation which is highly sensitive and specific, but strictly say no to 0.5 Tesla or 0.2 Tesla MRI and always get in whole spine screening. Because in early stage of infection, the mild edema will be missed in 0.5 Tesla or 0.2 Tesla. And when we are not getting whole spine screening, we might miss the skip lesions found in some case of infections. There are various features which differentiate between tuberculosis versus pyogenic infection. I will enumerate a few. The most common site of tuberculosis infection is thoracic or thoracolumbar junction, while pyogenic infection most commonly involves the lumbar spine. Coming to the tuberculosis infection, multiple vertebral body involvement or skip lesions are more common in tuberculosis, while in pyogenic infection, it most of the time it infects only a single level. Coming to paraspinal abscess, the paraspinal abscess the abscess is confined mainly to the disc space, or it may extend to the epidural space. When we subject the patient to contrast MRI, TB shows typical of thin-walled abscess, while pyogenic infection, the abscess will be thick-walled and it's an irregular abscess. Coming to vertebral body destruction, as I said earlier, vertebral body destruction and kyphotic deformity are more commonly seen in tuberculosis infection rather than in pyogenic infection. In pyogenic infection, most of the patients comes to us when there is just a disc space collapse. This is a classical example where a patient had severe pain, an MRI was taken and was reported normal. But you can see there is a mild increase in the edema in the T2 sagittal images. When the patient presented us after 2 months of persistent pain, we repeated the MRI scan where it has progressed to a full-blown pyogenic infection. So coming to other diagnostic modalities, blood investigation, ESR and CRP are elevated in more than 90% of the patients, but they are mainly useful in monitoring the treatment rather than in diagnosing them. They are called as corroboratory evidences for infection. Whenever your postoperative patient has persistent pain even after 2 to 3 weeks with mild fever, and if there is an CRP is persistently elevated after 2 weeks, you should always suspect infection. We should always search for potential cause of bacteremia which has led to pyogenic infection. So the recommended investigations are blood culture, urine culture, and echocardiogram. Blood culture is positive in 15 to 25% of patients. Urine culture, as I said earlier, is the most common identifiable cause of bacteremia, which is positive in 30% of patients. Echocardiogram is must in patients where there is multifocal infection. Say, for example, the patient is having spinal infection along with that septic arthritis of the shoulder or knee, we should always suspect infective endocarditis, and the cardiologist's opinion along with the echocardiogram is must in these kind of cases. To confirm the diagnosis, biopsy is always necessary. So I personally prefer a transpedicular biopsy under general anesthesia because we can add a good chunk of bone and comfortably. A CT-guided biopsy, when the patient cannot be subjected to an anesthesia, but the problem with CT-guided biopsy is the amount of bone we get is very less and chances of negative culture is more in those cases. Whenever the patient is having paraspinal abscess or psoas abscess, I don't go for biopsy. I go for ultrasound guided or CT guided aspiration of pus, and I just do the examination with the pus. To get positive culture, there are some recommendations. For bone specimen to give positive culture, it should be at least 3 to 4 mm punch should be there. If it is a sclerotic bone, better you go for second attempt, and if it is a moist cancellous bone, it's more appropriate. Usually, when you're giving a bone tissue for culture, what the microbiologists do is they crush it and make it homogeneous and spread over the culture media. So bigger, harder bone, the chance of negative culture is more. Whenever you are getting a pus, aspirated pus, I usually send it in the syringe itself. 0.5 ml to 2 ml is more than sufficient. Swab, if you are sending a swab, the chance of positive culture is very less. So whenever you are collecting a sample, either bone or pus, try to send it within half an hour to the microbiological department. And if it is getting delayed, you store it in the room temperature. Don't store it in the refrigerator. If possible, stop the antibiotics at least 2 to 3 days prior to the biopsy or proposed procedure. So as per literature, the most common organism encountered in pyogenic infection is Staph aureus, which is indicated in 50% of cases. Next comes gram-negative organisms such as E. coli, Protease, Pseudomonas, which is seen in 30% of cases. Other organisms are Coagulus negative Staphylococcus, which is seen in invasive spinal procedures. Anaerobic infection, though rare, it's seen in uncontrolled diabetic patients. Pseudomonas and Candida infections are common in IV drug users. So in our study, out of 49 patients of pyogenic infection plus 3 mixed infections, we had positive culture in 34 patients. That is 65% of patients we have positive cultures, and 18 patients had negative culture. Coming on to the microbiological spectrum, we had equal incidence of gram-positive infection compared to gram-negative infection. So you can see that Staph aureus and MRSA contribute to around 15 patients, while E. coli, Pseudomonas, Proteus contribute around the same amount of 14 number of patients. So in spite of our best effort, 35% of patients may not have a positive culture. In those cases, how to diagnose or brand them as pyogenic infection? So we should go for other investigative modalities. So this real-time PCR panels for bacteria is coming up in a big way. So whenever bacterial culture is negative, we can subject and we are strongly suspecting it as pyogenic infection. So you can suspect the specimen for PCR test. There are different bacterial panels available, and the only negative thing is the antibiotic sensitivity pattern will not be given. They can identify the organism. Next comes the histopathological examination. So many times when you send a bone for a pathologist, the most common finding we get is non-specific inflammation. That is the report we get. But you talk to your pathologist. So whenever it's a non-specific inflammation, when it is a lymphocyte predominance, we should think in more in terms of tuberculosis. When there is necrotic bone with neutrophils and macrophages, you should think more in terms of pyogenic infection. So this is the broad antibiotic protocol given in the literature, where there are 4 groups of organisms are there. First is gram-positive. If it is a gram-positive infection, it can be a methicillin sensitive, where we can use simple penicillin, first or second generation cephalosporins. If it is methicillin resistant, MRSA, we should go for vancomycin, teicoplanin or linezolid. Gram-negative bacteria, we can group it as Pseudomonas group or other than Pseudomonas group. Pseudomonas group, we should go for anti-pseudomonal beta-lactam agents or aminoglycosides. Other than Pseudomonas like E. coli or Proteus, either we should go for aminoglycosides or second or third generation cephalosporins. So in our study, according to the culture sensitivity pattern, gram-positive organisms showed good sensitivity to linezolid, vancomycin, rifampicin, and somewhat a good response to amikacin and oral antibiotics such as nitrofurantoin and clindamycin in around 50% of patients. Gram-negative infections, we had good sensitivity pattern to amikacin, cephalosporin sulbactam, piperacillin tazobactam. Other oral antibiotics such as levofloxacin, ciprofloxacin, cotrimoxazole, sensitivity was seen to these drugs in 30% of patients. There are some 1 or 2 patients where there was a drug resistant to all the available drugs, mainly in gram-negative infection. It was sensitive only to colistin, where we are forced to use colistin in those 2 cases. So our protocol is to give patients 6 weeks of IV antibiotics followed by 6 weeks of oral antibiotics. So coming to the treatment, the primary modality of treatment is antibiotics, appropriate antibiotics. It can be 6 weeks of IV followed by 6 weeks of oral antibiotics. Adequate rest should be given, support in the form of brace, and monitoring the response using clinical parameters, CRP and radiology. There are certain indications where we have to intervene, where the patient is having persistent pain even after starting appropriate antibiotic. The patient is having neurological deficit. There is a bony or dissection of the bone and failure of non-operative management. The goals of surgical intervention is mainly debridement of the infected tissue, drainage of abscess, decompression of the neurological tissues, and stabilization using pedicle screws. So I will show you some examples where we have treated patients operatively. So this is the MRI we have shown earlier. This is a 46-year-old female. Patient had recent history of urological procedure with urinary tract infection. She presented some 2 weeks, 2 to 3 weeks after the incidence of urinary tract infection. The initial MRI showed mild edema and L3, L4 level, which was not picked up. Later, when they presented to us, we repeated the MRI, where there was a frank pus in the L3, L4 disc space. We did a biopsy. There was no growth in the culture. So we we depend upon the urine culture sensitivity, which showed E. coli growth, and IV antibiotics was started. Patient didn't respond, so we went into operate. Transfemoral lumbar interbody fusion with the debridement of the disc space was done. This patient, the culture again showed E. coli and was sensitive only to colistin, and 6 weeks of IV colistin was given for this patient. You can see the MRI taken after 1 or 2 months, where there is a edema is completely subsided. So another case, 6-year-old male with L3, L4 infective spondylodiscitis. Patient was started on empirical antituberculous drugs, and patient came to us after 6 weeks of antituberculous drugs. Patient was having persistent pain, and we started developing some foot drop. So we took him for surgery. The culture of the disc space, the infected tissue showed Klebsiella growth. So we stopped antituberculous drugs. We started on Paraspinal tazobactam for 6 weeks. Patient improved and went on to fusion at the L3, L4 level. It's a case of a young school-going boy with L4, L5 disc prolapse. Patient was operated for discectomy was done outside. Patient presented us with post-operative spondylodiscitis. Since the patient was having very severe pain, we took him for surgery. Debridement and stabilization was done. The patient again showed pseudomonas growth and settled with appropriate IV antibiotics. This was a rather interesting case. 70-year-old male presented us with an acute onset pain with features of septicemia and progressing neurological deficit. MRI was done. MRI showed the infective focus at T8, T9 level, and there was an extensive epidural abscess starting from C3 extending up to thoracolumbar junction. There was almost more than 10 segments involved in the epidural abscess. Since the patient was having a quadriparesis, we took him for surgery. So we did a limited laminative approach where I exposed the whole 10 segments, and alternate level laminectomy was done, and I used a feeding tube to wash out the abscess. So the culture showed MRSA growth, and with the appropriate antibiotics, the patient improved, and now the patient is walking with support. It's almost 3 years follow-up now. So you can see the follow-up MRI, complete resolution of abscess starting from cervical spine to thoracolumbar spine. We didn't do any stabilization. So coming to the infection in the cervical spine, thoracic and lumbar spine, getting an pus aspirated done or getting a bone biopsy is comparatively easier. The cervical spine, getting an abscess drained or getting a bone biopsy is a little bit difficult compared to thoracic spine. So personally, whenever I get a cervical spine infection, I prefer more in terms of surgical treatment. This is a case of 45-year-old female with C5, C6 discitis with epidural abscess and neurological deficit. We went in, we did an anterior cervical discectomy, drainage of epidural abscess, and plating. So patient settled with appropriate IV antibiotics. So another case, 52-year-old male who is a chronic renal failure patient, so on alternate day dialysis, came with significant neck pain and neurological deficit. MRI showed C3, C4 infective spondylodiscitis with neurological deficit. So since he was a chronic renal failure patient, we suspected him to have a pyogenic infection. So we did an anterior cervical discectomy, drained the abscess, and fixed it. The growth was pseudomonas growth, and patient was started on cephalosporin sulbactam. Patient improved well. After 6 months, the patient again presented us with a significant back pain. We took a repeat MRI scan. We saw that at cervical level, the infection has completely settled down. There is a new foci of infection at the L3, L4 level. Since there was no neurological compression or destruction of bone, we just did a CT aspiration of pus, and the organism grown was again the same Pseudomonas organism sensitive to same set of antibiotics. So we started him again on cephalosporin sulbactam, and the patient settled with 6 weeks of IV antibiotics followed by 6 weeks of oral antibiotics. It's again an interesting case. A 54-year-old male, again a chronic renal failure patient on hemodialysis. Patient had a T11, T12 spondylodiscitis. Again, the patient was started on antituberculous drugs outside. They present to us after 2 weeks. Patient was having very severe pain. So we thought it's a patient is a chronic renal failure patient on hemodialysis. We suspected it to be a pyogenic infection. We stopped the antituberculous drugs. We took him for surgery. We did a transpedicular debridement of the disc space, stabilized it, and the Pseudomonas organism was grown. and the patient was started on appropriate antibiotics. Piperacillin tazobactam was started for this patient. Patient improved well. After 2 months, patient was ambulant, no pain was there, antibiotics were stopped. After 2 months of completion of antibiotics, patient again presented with a severe back pain. So we took a repeat MRI scan. We saw at a T11, T12 level, there was no edema. You can see the stir image, edema at T10, T11 level. So we thought that the patient will be having same kind of infection. So since there was no abscess at the earlier MRI, we didn't do any biopsy. We just started on piperacillin tazobactam as it was the previous culture sensitive antibiotic. But patient didn't have any improvement. After 3 weeks, we repeated the MRI scan, where you can see there is an abscess formation at the level above. Previously, there was an abscess formation as T11, T12. Now the abscess formation is at the T10, T11 level. So it was flowing down the epidural abscess. So we did again repeat CT guided aspiration of the pus. There was no organism grown. Then we send the same pus for bacterial PCR assay. So previously it was Pseudomonas infection. Now bacterial PCR assay showed E. coli infection. There was no Pseudomonas infection. E. coli, different organism was there. We didn't get any clue regarding the sensitive antibiotic. But since patient was not responding to piperacillin tazobactam, we started him on colistin, dose adjusted according to his renal parameters, and patient improved. So to conclude, because of the growing elderly population, improved diagnostic methods, and increasing spine surgeries, there is an increased incidence of pyogenic spondylodiscitis. There is in our center, in our study, the incidence of pyogenic spondylodiscitis is 35%. And the prognosis mainly depends upon bacteriological diagnosis and starting on appropriate IV antibiotics. 34% of patients will have culture negativity. You have to depend upon other corroborative evidence to start on to diagnose it as pyogenic infection, and we have to start on empirical IV antibiotics. In our center, the most common empirical IV antibiotic we start is for gram-positive coverage, we start on linezolid. For gram-negative coverage, we start on amikacin. And then if there is no growth in culture, we continue it for 2 weeks. Then we change it to oral antibiotics. Thank you.
That was a very good presentation, sir.
Ram, thank you.
That was a very good presentation, yeah. I request our participants to unmute themselves to ask queries if you can, if you want. And some people have posted some queries in the chat. One first question is Dr. Karthik Anand. Karthik, can you hear us? You can unmute yourself. Dr. Karthik?
Yeah, I can hear you.
Yeah, you have a question to Dr. Vishnu.
Yeah, Dr. Vishnu, for me, the common thing is we encounter a lot of sacroiliitis patients.
Okay,
right?
okay.
There is some edema, there is some erosion. That is what the picture, the MRI reports will be finally. And we are unsure whether it is infection or it is or inflammatory ileitis. Or so, how do you proceed from there? Like, to directly go for a biopsy, or the other parameters you into, or
yes. We are also having we have also encountered the same problem. Patient coming with back pain, we do an MRI. Patient will have an unilateral sacroiliitis. Usually, we discuss with the radiologist. They say that if there is only edema, it is most probably an inflammatory arthritis of the sacroilium. If it is infection, there will be some bony erosions along with some minimal collection in the MRI. So if they say that there is a minimal erosion and minimal collection, we go ahead with CT guided aspiration or a biopsy of the SA joint.
Okay.
If they say that there is no collection, there is no erosion, we term it as inflammatory arthritis, and we get a rheumatologist opinion. But to be frank, there are some few conditions where we suspected it to be a tuberculous sacroiliitis, We start on ATT. After a few months, patient will have present to us with typical features of inflammatory arthritis, like involvement of the other side of the SI joint.
Yeah.
In that
So
case,
you don't start on empirical antibiotics.
so usually most 90% of them, I convince the patient to get a biopsy done.
Okay. But most of the time, again, the biopsy results are also negative.
Yes, yes. So things. So for example, if the patient is having the radiologist is saying it as infective sacroiliitis, we are getting a biopsy done. It's all inconclusive. So in that case, I start them on empirical ATT.
ATT. Okay.
Yes.
So you are more into TB in case of sacroiliac rather than the pyogenic.
Pyogenic.
That
Dr. Vishnu?
question.
Yes.
Dr. Vishnu?
Please
Yes, sir.
introduce yourself.
Frank of Salem.
Yes, sir. Thank you, sir.
Welcome, sir. Ask your question, sir.
Have you had any incidents of implant infection following stabilization?
Yes, sir. Yes, sir. I've got a few infections where following transfemoral lumbar interbody fusion or following spine fracture fixation or even following deformity correction, I've got infections.
No. What I meant was implant infection for pyogenic discitis, where you have instability, you have fallen. If
Foot implant.
developing.
No, sir. Not even in a single case. Not even a single case, and I don't think twice before putting an implant. If there is instability, even there is a francus, we can put. There is ample evidence suggesting that stabilization helps in healing of infection.
So with that question continuing, so one of Dr. Sharat Chandra, he asked one question regarding the use of titanium cages in pyogenic discitis when you do a debridement, disc debridement. And the other question was, which is preferred, the cage or the autologous graft?
Yes. So as I said earlier, whenever in case of tuberculosis, the bony destruction is more and the anterior gap will be more. We have to support it with a cage. In pyogenic infection, most of the time, the patient just presents the disc space collapse. If the disc space collapse is very less, we can get away just with an autologous bone graft. If you think the disc space is the dissection is more and there is an empty space, we can use a bone cage. But in most of my cases, you can see that my instrumentation is just limited to single segment. If there is an L4, L5 infective spondylodiscitis, I just use implants in the L4, L5 level. So in this case of monosegmental fixation, I prefer cages to give more stability so that we can mobilize the patient earlier. So putting a cage inside the infected disc space doesn't increase the chance of infection, and it aids in faster pain relief. So far, I didn't have any problem after putting a cage in the infected disc space.
Yeah, I agree with the point even, but whenever the condition provides that just getting up with just the local bone grafts or even if iliac graft
more than sufficient,
putting another metal is always scary, but yeah,
it's a surgeon's preference. It's not mandatory to put a graft. It's a surgeon's preference.
Yeah, but it is not a contradiction. I agree with that.
Yes.
So one more question, Dr. Nikunj, you are there. You can ask question. Dr. Nikunj. Okay. Dr. Nikunj's question is the role of teriparatite in discitis.
Role of teriparatite in infective discitis. Yeah. So far, I have not used. I have not used. I don't have a.
Probably was looking into asking osteoporosis and the spondylodiscitis. Will you use teriparatite or not?
Okay, mostly I have not. Frankly speaking, I have not used. If the patient is having severe osteoporosis to aid healing, we can use. Do you have any experience, Ram?
No, sir. No, I don't use as such. Okay. Then the next question is: how do you decide for treatment, drugs, pyogenic versus TB, when everything is negative? Say you have done a biopsy, it's negative. Whether you will go for an empirical ATT or you follow, it's basically a culture negative and a biopsy negative.
Okay.
which talking.
Okay.
Dr. Hamza.
There are certain points I follow. As I said in that there are certain things we can pick up from the patient. If the patient is septic, if the patient is having high grade fever, and the MRI is showing more in favor of pyogenic infection, and the patient is having some uncontrolled diabetes or immunocompromised status, I go in. I literally think it as a pyogenic infection. Start on IV antibiotics covering both gram positive and gram negative organism. If it is not there, patient is not having any septic features, so thoracic, thoracolumbar spine, and the MRI are more suggestive of tuberculosis, I will go for empirical ATT. But as I said earlier, in rifampicin in our study, rifampicin is covering most of the Staphylococcus aureus and MRSA. So if at all you are starting empirical ATT, if the patient is having gram positive infection, the ATT will take care of the gram positive infection also.
So in that scenario,
Yes.
when everything comes negative and
Yes.
you're not inclined towards TB nor towards pyogenic, how will you manage?
Yes.
It's like a scenario where you're clinically you're not able to diagnose as well. Your biopsy is also
Yes.
happens actually,
Yes.
right?
So
You agree,
in
right?
that case, there are few examples I will give you. There was an over a 60-year-old female with thoracolumbar junction infective spondylodiscitis. We thought it is like in tuberculosis, but all came negative. We started the patient on antituberculous drugs. 6 weeks antituberculous drugs, patient was not at all responding. Then we saw that okay, 6 weeks patient is not responding. Along with this thing, we started on IV antibiotics. The patient responded. So we stopped and we thought, okay, the patient is not responding to even after 6 to 8 weeks of antituberculous drugs, but patient responded once we started IV antibiotics. We stopped antituberculous drugs. We continued with the IV antibiotics and considered as pyogenic infection.
And
So
then you literally drop
yes, we literally treated as a pyogenic infection. We stopped antituberculous drugs.
Okay.
Okay, so it's always a confusion. It's always a confusion. So even after taking this thing, we can start on antituberculous drugs. Monitor the patient closely. If they are responding, it's well and good. So if the patient is having TB or gram-positive infection, they will respond. If only the particular group of patients with the gram-negative infection will not respond. So in that case, if the patient is not responding even after getting adequate treatment for 8 weeks, then we can switch over to IV antibiotics.
Hello.
Hello.
Yeah.
Hello.
Yeah, introduce yourself.
Yes, sir. How are you, sir?
Very fine.
How do you check the response, sir? By MRI or by blood investigation?
So usually I don't do any MRI. So if I give clinical response, whether the patient is having pain relief or not. Second, I usually check CRP for pyogenic infections and X-ray. So if the X-ray there is no increase in the destruction of bone, patient is having pain-free period, and the CRP is in downward trend, the patient is responding. I don't go for MRI.
So you think ESR is a better biochemical marker than CRP, or CRP is better than ESR?
I think CRP is better
because
in case of pyogenic infection.
TB, they advise to check ESR instead of CRP because normally in TB the CRP level is always in a mildly elevated
Higher level.
case. What I see, yeah, mildly not much elevated, yeah.
So okay, in pyogenic infection, I prefer CRP. In tuberculous infection, I prefer TB.
Oh, good.
So the continuation of the
I go for MRI scan if the patient is culture positive. I'm giving IV antibiotics. The patient is not responding. I'm not seeing the response. Then I go for MRI scan at the end of 6 weeks whether the edema has subsided or not.
Can you share your experience in multi-drug resistant TB?
No, so far I have not even treated a single case of multi-drug resistant TB.
Or like the TB, you tend to operate twice or thrice within 2 years. They keep on first pouring.
Yes. There are some 2-3 cases where I have seen TB late responders. An example, the patient with HIV positive patient with tuberculosis infection. There was a lot of paraspinal abscess. We aspirated. TB PCR showed this tuberculosis infection sensitive to rifampicin. We started on antituberculous drugs. Even after 1 year, patient was having mild symptoms with the MRI showing persistent pulse. But over a period of 18 months, patient responded. There are few cases where the patient responded late, but I haven't encountered a patient where they've multiple recurrent tuberculosis.
Sir, is there any role of the procalcitonin in pyogenic spondylodiscitis?
So procalcitonin, there are one or two patients where the patient got admitted. I saw a patient with extended epidural abscess. The patient was having septicemia. Patient was admitted in ICU, where the intensivists, they prefer procalcitonin to monitor the response. So in acute stage, in a very acute stage, procalcitonin might be helpful to show that the patient is having septicemia. But in continuous monitoring, I think CRP is preferable, more affordable compared to procalcitonin.
Yeah, that is true. More than affordability, the procalcitonin is to see the septic level, whether the kidney, liver, everything is going, or a multi-organ dysfunction. That is useful. But for just to monitor the pyogenic, this one procalcitonin is not much useful.
Yeah.
Yes,
Localized infection better will be going ahead with CRP. So, continuation of that. What
Dr.
investigation?
Vishnu,
Okay.
Yes, Shakti.
Do you have any preference to like the patient who presents like a pyogenic immediately or a failed back with infection? Whether the treatment changes?
I'm not getting a question.
No. The patient who directly presents like a pyogenic only for infection or a failed back, operated somewhere else, comes out with the infection. Whether the protocol
definitely. Whenever there is a post-operative disc space infection, I prefer to go in and debride it.
Yeah.
While in case of pyogenic infection coming without a history of surgery, if the patient is not having any neurological deficit or the patient bone district pain is not much, I prefer biopsy first.
Okay, Dr. Vishnu, the question is,
yes, Ram.
What biopsy? Is it CT guided biopsy or a GA fluoroscopic biopsy? And what do you prefer? And in that,
if the patient is having any paravertebral abscess or a psoas abscess which can be aspirated, I send it to the radiologist. They will do a CT guided aspiration of pus, ultrasound guided aspiration of pus. If there is no aspirable pus is there, we have to get a biopsy from disc space or from the bone. I prefer a biopsy under general anesthesia, transpedicular biopsy using Jamshiti needle.
Okay.
I don't rely on a CT guided biopsy.
And Dr. Vishnu, when you aspirate, what all the tests you want to send? The pus, like the TB culture, regular culture, what all things you want to send it for?
If I am getting a pus aspirated, I will send for gram staining, AFP staining, pus cultural sensitivity, and TB PCR. 4 tests.
You send rapid TB PCR or just normal TB culture? Because the rapid TB PCR is earlier, but they test only 4 or 5 drugs, I think so.
Yes, since in my experience, I have not seen very much case of multi-drug-resistant tuberculosis. I send for rapid TB PCR.
Okay.
Dr. Vishnu, good evening.
Good evening, sir.
Introduce yourself, sir.
Over here, sir.
Pardon?
Gurdeep over here, sir.
Yeah, Gurdeep. Go ahead.
Just one question. I mean, in pyogenic spondylodiscitis in the lumbar spine, when there is a big void and you want to reconstruct it, I mean, the normal T-leaf cage is not big enough. How do you reconstruct? With a mesh cage or do you prefer a iliac graft?
See, if there is a big void, till now I haven't used a mesh cage in lumbar spine. So I have got a company supplying a T-leaf cage ranging up to 17 mm. Normal T-leaf cage, they come out till only they will give around 12 mm. So I have got cages, T-leaf rectangular cages up to 17 mm. And if you ask specifically, they can provide up to 18 mm cages also they are providing. So that those kind of cages are easy to introduce in the lumbar spine, where you cannot sacrifice the nerve roots for the sake of introducing the cage. So either you can do that, or I used from posterior iliac crest, I harvest a large amount of graft and just pack it. Either of the two. So I don't have any experience of using a mesh cage in lumbar spine.
In these cases, do you mobilize them a little later on, or you are okay to mobilize them early?
So in case of very large void, I always use a large size rectangular cage and use them mobilize earlier with a brace, a second or third post-op day.
Okay.
Yeah. Dr. Ramkrishna, you want to ask something? You can go ahead.
Yeah.
Ramkrishna?
Yeah. Can you hear me?
Yeah.
Dr. Ram?
Sir, I'm hearing you.
Yeah. So first of all, it's a very good presentation, and
Thank you, sir.
this is very challenging for all the spine surgeons. There's so many doubts right from the patient comes in, how to start off with a diagnosis, how to treat the patient, what antibiotic, should we do a surgery? So there's so many burning questions.
Yes,
So
sir.
you have presented it very well, and I have two questions. Most of them were answered earlier, and one thing is if you're treating some gram negative,
Yes.
biopsy negative, if you get it, and if you're
Yes.
treating that patient, you told that you will go with a broad spectrum antibiotic, and that is
Yes.
for how many weeks, and how would you decide? Would you usually what we practice is what we were taught is to follow it up with a total count, ESR as well as CRP.
Yes.
So and if you have still doubt whether it is a TB or pyogenic, you consider HP, which shows, as you well said, if it is lymphocyte predominant, you start empirical ATT and C, and if it is a neutrophilic predominant, then probably you'll start a broad spectrum antibiotic.
Pyogenic. Yes,
The pyogenic. So what is the duration? Is it any specific 6 weeks? Is it is a literature given, or how do you go about it? And the second question is, at what stage you decide whether to fuse the patient or to treat him conservatively?
Okay. So for first part of the question, so culture negative, we are thinking it as pyogenic infection. So what antibiotic will start? So we are starting IV antibiotics covering both gram positive and gram negative.
Yes.
So we are giving it for a minimum of 2 to 3 weeks.
Okay.
So if the patient is responding well, and the patient's CRP is significantly falling down, what I do is, for example, if there is a gram positive, I'm giving linezolid, gram negative, I'm giving amikacin. At the end of 2 weeks, I stop linezolid because we cannot prolong linezolid because it might cause a bone marrow suppression. So I change it to tablet clindamycin for gram positive, and I continue with injection amikacin for 6 weeks. So in our study, we have shown that amikacin is having 75% of sensitivity to gram positive organism also. So in fact, it covers both MRSA and gram negative, and added to that, I will giving clindamycin also. At the end of 6 weeks, the patient is improving well. We stop injection amikacin and give oral substitute for gram negative, either ciprofloxacin or cotrimoxazole. And we continue both clindamycin and cotrimoxazole for another 6 weeks. Total 12 weeks.
So giving amikacin for so many days, is it advisable? Because
yes, so I will discuss with the floor. Yes. If the patient is old age patient, comorbidities, they cannot tolerate amikacin, we substitute with ceftazidime sulbactam or piperacillin tazobactam to cover gram negative.
Okay.
So, but the one method I follow to decrease the chance of renal failure in amikacin is I give 500 plus 500 1 gram as a single dose, morning dose alone.
Okay.
So they say that the renal failure associated with amikacin is not the duration to which the patient is exposed to drug, not to the dosage. So if you are splitting the dose and giving us a BD dose, the chance of renal failure is little bit higher. When you give it as a single dose, the chance of the renal failure is little bit less.
Okay.
Yeah, that was a valid point here.
And about the surgery, at what level would you decide whether
yes. So for example, if for thoracolumbar spine or lumbar spine, if I'm getting a biopsy done or getting a culture done and starting on IV antibiotics, patient is responding well and good. If the patient is having significant pain, so anyway, the bony destruction or neurological deficit is not going to occur in a faster way because already we are starting on IV antibiotics. If the patient is having significant pain, not able to walk because of pain, at the end of minimum of 3 weeks of IV antibiotics, then I decide we have to operate on this patient.
Okay.
But I always give the patient, if you can tolerate the pain, you can wait for another 3 weeks. The patient is saying, I'm not able to tolerate pain. My cutoff period for response to see the response in IV antibiotics is 3 weeks. Like we have around 6 to 8 weeks in ATT. I give 3 weeks of IV antibiotics for the pyogenic infection patient. It's
All right.
not given anywhere in the literature, but it's my policy to follow this.
Yeah, but you have found good results with those.
Yes, definitely.
Yeah. Thank you, doctor.
Dr. Ajay Prasath sir has joined us. Any valuable points, sir? Dr. Ajay Prasath sir. Dr. Ajay Prasath sir. I think he is not hearing us. Dr. Bharani, you wanted some questions. Yeah, Dr. Bharani.
Yeah, Dr. Vishnu, it was a good presentation.
Thank you, Dr. Bharani.
Yeah, I have certain questions for you. The one cervical spine anterior fusion that you have done, did you use a graft there, tricortical graft?
Yes, definitely.
Okay, so you didn't have any issues in that? Any
No.
graft placement
So, okay.
at the infection?
No, nothing. So we debrided. So actually, in the second case, you can see that there was after a few days we saw collapse of the disc also, but it went on to uneventful healing.
Okay, so that was after you ensure that debridement is complete. You
Yes.
in the graft inside.
Yes.
Okay.
Yes.
And
Yes.
the other one is, what is your threshold for a trial ATT? How many weeks generally do you believe it should be given before you?
Sir, like I said, I just wait. If I'm giving a patient with a doubtful diagnosis, I'm starting an antituberculous drugs. I wait minimum of 6 to 8 weeks. 6 to 8 weeks. I tell the patient that this I'm starting a trial drug. The response time will be minimum of 6 to 8 weeks.
So do you image them in between? Do you take any X-rays or something? You monitor blood count?
Just clinical examination, pain, VAS score, and ESR,
Okay.
and X-ray, X-ray of course, but not MRI.
Okay. All right, done. The other thing I wanted to add something about the mesh cage. There was a question about mesh cage usage.
Yes.
This one I have a good amount of experience in using mesh cages for lower lumbar areas. Especially we tend to use it more for even regular PLS. We used to do it during our fellowship days also. But here,
yes, I heard this. I heard this with Dr. Venkatesh. He said that whenever you're reducing a high-grade listhesis, when you use mesh cage, the chance of losing the reduction is much less when you use a mesh cage.
Yes. The reason why I'm highlighting it is when you're going for a vertebral destruction reasons, anterior column, the destruction may not be uniform all through it. Sometimes it may be irregular, more on one side and the other side may be less. So in case you are shoving in a TLIF or a PLF cage, it may not have a press fit. It may be loose no matter how big you use it. So in such instances, I usually keep this as a backup. I keep a mesh cage, 10 mm size diameter cage with me.
Okay.
So I try to put a longer one on one side and a smaller one on the other side and try to compress it and then get a good fusion bed. So that is one thing I usually keep it as a...
Okay. I always have a difficulty in introducing that mesh cage into the lumbar disc space.
Yes,
any ideas or surgical?
It's usually you tilt it and introduce it and then make it vertical. That is the regular thing, but it has high chances of your dural nerve root injury and all that. Only thing is you should have the confidence of using it. But once the compression and immediate stability what you get in irregular destruction is much better than what you get in a TLF cages. And sometimes they do retropulse. These cages, when you're putting in irregular cavities, they do retropulse. That is one thing we can take it as a backup.
Definitely.
Other point I wanted to add is this pyogenic infection, Salmonella is claimed to be one relatively unappreciated organism causing pyogenic infections, especially in lower lumbar areas.
Okay. Actually, we have one infection recently, case Salmonella. So whatever, we don't have much experience in it.
In fact, from CMC we have a paper, and after this is published way back 2010, close to 2010, something they published it. But recently also there are a lot of publications coming up about Salmonella infection mimicking TB. So simple Vidal is good enough. So that would be ideal to have it in the panel of investigations what we do when you're suspecting pyogenic. A simple Vidal, which is a specific test, even though the cultures can be negative, sometimes they may not have preceding GA symptoms also. Cultures may be negative for Salmonella. Still, Vidal will be positive. So it's simple investigation, blood investigation that will help us. That is one thing.
Okay.
And Dr.
I
Bharani.
have a question for you, Dr. Bharani.
Yeah, tell me.
So as I said that my choice of drugs for empirical antibiotics is linezolid and amikacin, because in our microbiology class we have got this two drugs. So in CMC Vellore, what is the drug of preference is the empirical antibiotics we use to cover the gram positive, gram negative?
Biopsy positive, nil culture pyogenic infections are treated with fluoxetine or cefazolin as IV for initial 2 weeks.
Okay.
With cifran IV.
Okay.
IV ciprofloxacin for 2 weeks, and it is followed by another 6 weeks of oral antibiotics.
Okay.
So, I'm sorry. It's a 12 weeks regimen. 2 weeks of IV followed by 10 weeks of oral. Initial 2 weeks is IV flox or cefazolin with cifran. Next 10 weeks is oral fluoxetine or ceftum with oral cifran. This is the protocol we follow. And
if the patient is not responding adequately, do you give higher antibiotics?
Yeah, if they are not responding, that the clinical response, as you told me, pain and your ESR CRP is all we monitor. So if they are not responding with this, we may escalate it.
Okay, good. Thank you.
So otherwise, because the 6 weeks IV we don't routinely practice because it's going to be tedious and expensive. Monitoring IV cannula, a lot of things are involved in it.
Yes.
We are pushing linezolid and other things for longer duration. They can have antibiotic-induced other side effects also.
Definitely.
I think Dr. Shakti wants to add some point. Shakti, go ahead.
No, actually, I want just want to ask Dr. Bharani. Dr. Bharani used 2 harms cage, mesh cage for lower lumbar. This one or a single mesh cage?
Single flip cage. If the destruction seems more irregular, more cavity on one side and a smaller cavity on the other side, we don't try to push in similar cages on both sides. Undersize one on one side and put a longer cage on the other side, so that the lordus is maintained.
Yeah, so normally you try to use 2 cages in case of a lower lumbar, like L5S1 or L4S5.
No, we usually put a single cage. If we are using a harms cage, some surgeons put 2 cages, smaller ones on either side. If you are using a T-lift cage, it's usually a single. PLAF cages, you have to, for ideal things, you have to put 2 cages on either side. Ideal PLAF is done that way. The cost cutting procedure, what we do is posterior oblique lumbar antibody, POILF, what we call it. Single oblique cage, what we push it in, is we are doing it for cost cutting reasons. But when vertebral body is destroyed, you cannot do that. You cannot push it obliquely, or you cannot push it straight, because it's going to wobble or it's going to retropulse. So you can put a longer cage on one side and try to compress it. If it is stable, put a smaller cage on the other side. Because
so when you put them, that's a point well taken, sir. But when you use a arms cage, you go through like flip approach or T-lift approach.
Flip approach.
Flip approach. Okay.
Flip approach, because you need to have more dural retraction to ensure that you can tilt the cage and go inside and then put it. Yeah. Through the foramen, taking in a 10 mm cage which has got spikes is difficult. You will definitely injure the root or the dura.
2 points well taken, sir. One is Vidal test for Salmonella and this one arms cage. Anyway, thanks a lot.
Dr. Ajay, sir. Okay. Dr. Vishnu, I have 2 questions for you.
Yes.
Do you have experience with fungal spondylodiscitis?
not exactly.
Okay. And,
Actually, I have a case of fungal spondylodiscitis,
okay.
which 3 times we debrided,
Okay.
which is a post-op fungal infection.
Mm-hmm.
And the patient was in ICU for a long time with all higher antibiotics and even on antifungal.
Mm-hmm.
But fortunately, she recovered.
What antifungal you used?
Usually oregano.
I have to just
The
check it.
diagnosis
Almost
of antifungal was based on fungal culture.
Fungal culture. It was a post-op discitis. It was a post-op discitis.
Okay. We had 2 cases. One case came from West Bengal. Somebody has put a needle saying therapy, and she had fungal infection. And one is primary. He's a diabetic without any interventions, and he had both responded well with oriconazole.
Okay, so in your as I said, when you are seeing a patient of discitis, you always send for fungal culture also.
Exactly. Yes, we always send for fungal culture also. But it will be like always send for. And one more guy has asked about anaerobic. You have any experience with anaerobic cultures?
No, I haven't come across any anaerobic infection.
Okay, so we send it like aerobic, anaerobic, and fungal.
Okay, so usually what when you are actually when we send pus for cultural sensitivity, microbiologists here they give us a clue that there is a fungal growth is there. That in microscopy, there's a fungal colonies are seen like that. So once they said it's a Canada is there, but it was insignificant. We saw it as a commensal. There was a fungal MRSA growth was also there, but I haven't had a direct experience of treating a fungal infection.
But when we send aerobic culture, anaerobic culture, and fungal culture, the cost of the investigation will go up for normal patients.
Definitely. Yeah. It goes high, but worth not to miss any of the things. That's what we
That is true, sir. But like places like what me and Vishnu practice, it's really just 80 kilometers away. So here the problem is costs. I don't know what we will.
Simple KOH mount should be a
KOH mount. Yes.
No stains. We do stains. Yeah, we do stains as well.
Okay.
But yeah, we don't.
But KOH mount initially, if you have any suspicion about a fungal infection, then you can take the sample for the culture. So usually it's better to go with the KOH mount instead of sending all the samples for culture. As we said, every patient cannot afford. If any suspicion of fungal thing in KOH mount, then the sample from the sample they can send it for the fungal culture as well.
Yeah, that's true. But most of the times, scenario what happens? Yeah. The scenario happens.
One more problem.
Just will ask some more samples after 2 days.
Yes. That was I always say. The amount of sample we get is also limited. We have to shift it to some 2-3 investigations. That also becomes a problem. So when you are operating on the patient, we get adequate amount of sample. But when you are doing a transcritical biopsy or CT gated biopsy, then the problem comes.
Yeah. Dr. James, sir, your points, any points to be added up, please. Dr. James from Coimbatore, Ortho 1. Is he with us? Professor James Nyanadas. Okay. So we are almost at the end of this presentation. It was
unmuted.
Sorry, Ram.
Yes, sir. Please.
I didn't realize I had unmuted my this thing.
Yes,
sir. I'm sorry, Dr. Vishnu. I missed your
good evening, sir.
Good evening. I missed your major presentation because certain technical I had here. But whatever it is, I think your comments on antibiotics cover is fair enough, and it goes on. And only one case of salmonella we had seen. 2005 or so, we published a paper, and it was presented in TNOA Con by one of my colleagues from PIMS Pondicherry. We had about 10 to 12 cases. After that, quite a few cases regularly we have seen. I mean,
Okay, sir.
but the point is acute pain, fever, and toxic symptoms, and spasm, and difficulty in even sitting up. So we never give much of this thing, because I prefer to, early phase, I used to treat them conservatively. Later, I decided why subject the patient to such a this thing. And whenever you do a biopsy needle, we found it is negative, and we didn't get any positive culture. We couldn't identify the culture, and this was a major problem. So I believed in stabilization and fusion. And in the lumbar, we have done a few with the Harm's cages, and we used to go laterally and push it. And because it is an irregular destruction, so part of it filled with the graft and part of it with the cage. But of course, combination of tuberculosis and drug-resistant tuberculosis, we have had one or two. While in Mayotte, as a surgeon there, I remember 2 cases which came with the drug-resistant tuberculosis. We had to change, and we had to go on multi-drug and this thing. But combination of the pyogenic and tuberculosis, we have not had much experience or observed it. Of course, you have seen this thing, but dorsal spine is also very, very limited experience. Most of them were lumbar spine.
Yes, sir.
And cervical, no, I've had no experience on that. But still, the principle remains: early intervention, clear debridement, clear it, stabilize it, put a good graft or put a cage, as you say, and mobilize it. And antibiotics can follow, because it will reduce a lot of morbidity and suffering for the patient. This is what I feel. I don't know. I mean, what is your opinion
Point
on
was
that?
taken, sir. That point was taken.
Thank you, sir.
Early
Thank you, sir.
mobilization is the key in most of our patients. Thanks.
Yes.
Thanks for that comments. So that was an excellent session today, sir. Vishnu, sir, it was an excellent session. A lot of discussions.
Thank you, Ram.
I hope all participants were completely understood about the concepts, and it was well good.
Thank you.
So we'll be meeting soon in day after tomorrow with one more session, which I will be uploading it shortly. Thanks again. Thanks.
Thank you, Ram. Thank you, Ram, for the opportunity. Bye.
Thank you very much. Good night.
Thank you, sir.
Thank you, sir.
Good night.
Nice presentation, doctor.
Good night.
Thank you, sir. Thank you, sir.
Bye.